Good morning. Again, thank you for having me to this wonderful conference. I have to say that I have done a lot of traveling as a neonatologist, and I must say that Panama is the most fun country that I have ever been in. I am going to talk about the very new guidelines for resuscitation, focusing on the premature infant. What is new and why is there a change? So the International Liaison Committee on Resuscitation, or ILCOR, which we follow all over the world for guidelines for neonatal, pediatric, and adult resuscitation, meets every 5 years to develop scientific consensus statements. And they interview look at international review of the world's literature, consider the science, and then they make new recommendations for resuscitation. And this most recently happened in 2015. And so this is the American Neonatal Resuscitation book that just came out a few months ago. And I would say that most of the countries in the world use some variation of this book. This book is also available in Spanish. So there is a new algorithm. It's very similar, but it's not exactly the same, so I will go through this in more detail. But I think you all are familiar with this, starting with the very beginning and finishing when the baby is still most critically ill. But we will go through this in more detail. So just to highlight, what are the newest changes in the recommendations for neonatal resuscitation? Now there is a very strong recommendation to begin with antenatal counseling. Now that we are resuscitating 22, 23, 24-week infants, it is important to discuss the plan and the outcomes with the family. It is important to start the resuscitation with a team briefing and an equipment check or a checklist. Now we universally recommend, if possible, delayed cord clamping for 30 to 60 seconds, especially for premature infants where the evidence is very strong, and that is strongly encouraged. There is a new emphasis on maintaining the baby's body temperature throughout the resuscitation. And the oxygen recommendations are now for premature infants to even start anywhere from 21 to 30%. We don't know the best number. We know that 100% oxygen is too high, but there is some evidence that even starting with room air may be okay in premature infants. If positive pressure ventilation is needed during the resuscitation, use a device that can provide PEEP, and a self-inflating bag is not able to provide PEEP, so it is recommended not to use that if possible. Ensure that ventilation provides inflation and movement of the chest, and it is most important to follow the heart rate. If you do need chest compressions, it is strongly recommended to intubate and to use a cardiac monitor when starting chest compressions or positive pressure ventilation. Again, there should be effective positive pressure ventilation via an ET tube for 30 seconds prior to starting chest compressions. The two-thumb technique for chest compressions are recommended. An epinephrine should only be administered after 30 seconds of positive pressure ventilation and an additional 60 seconds of chest compressions. And then it's important to debrief with the team once resuscitation has ended. So those were the highlights. I'm going to go through all of that in more detail and give you the evidence for those newest recommendations. So again, preparing for delivery and resuscitation and the initial steps. So here, antenatal counseling is in the algorithm, team briefing and checking all of the equipment. The baby is born after delayed cord clamping, and again, the three questions are, is the baby term? Is there good tone? Is the baby breathing or crying? Now for us, we're only looking at premature babies, so we're going down this pathway. So again, preparing for the delivery. It is very important when there are lethal abnormalities, or in this case, prematurity, discussing with the family the outcomes and whether everyone agrees to resuscitate or to provide comfort care for that baby. It is important to discuss with the obstetricians, are they going to do delayed cord clamping? And as you all know, 30 to 60 seconds is a very long time when you're waiting for a baby that you expect to need to resuscitate. Make sure that all of the team members have an assignment, the doctor, the nurse, the respiratory therapist, that there's someone is to record and add people as needed for lines and medication, equipment check, and using checklists. So has everyone here flown on a plane? And you know your pilot, every single time, even if they've flown 100 times or 200 times, they use a checklist every single time to make sure the plane is safe and that the plane will land safely. We should be doing that for every single resuscitation, making sure every piece of equipment is ready and everybody knows exactly what to do and that you have checked it off on a checklist. So this is the checklist that we use in the Mississippi Perinatal Collaborative, but it's very similar to checklists that are used all over the U.S. We talk about whether there was a consult, everyone's name and their roles, what we're doing to keep the temperature up, what the history was, and then our equipment check. And some places indicate who is responsible for checking all of this equipment. You usually have a few minutes to prepare for this, and it is important to do this for each and every baby that you expect you will need to resuscitate. What is the equipment that you need? For the premature baby, it's very important to have a hat and a bag and a warming mattress for the very smallest. We're pretty good about putting the baby in a plastic bag, but most of the heat is lost through the baby's head, and it's important to have a hat. The pulse oximeter, the cardiac monitor, a device for positive pressure ventilation, and the mask. And if you expect to need to intubate, the appropriate size laryngoscope and ET tube, making sure you have an oxygen source and a blender, and that lines and medications are available. Delayed cord clamping is the new recommendation for 30 to 60 seconds. Many of you are doing this already. And again, you can see here that as time goes on, less and less blood is in the cord because it is in the baby. We recommend, if possible, placing the baby on the mother's abdomen with the cord connected or being held in a warm blanket. As we said, skin to skin with the mother, held in a warm, dry blanket. And for the very premature, you can put the baby in the polyethylene plastic bag while you're doing delayed cord clamping. Of course, if there's a placental abruption, a cord avulsion, or if the baby has no heart rate and appears to need immediate resuscitation, you can defer the delayed cord clamping. Is cord clamping effective? In premature infants, there was a study that showed no difference in the outcome of mortality or severe IVH, but IVH in general favored cord clamping. And we also know that there is more blood pressure stability, less hypotension, and other improved outcomes, less need for dopamine or dobutamine in premature infants that have had delayed cord clamping. There is insufficient evidence if the baby is not very vigorous or is preterm, and the time of birth is still when the baby is delivered, not when the cord is clamped. Cord milking is the process of very rapidly pushing the blood into the baby from the placenta when you don't have time to do the delayed cord clamping. There, at this point, is not enough evidence to say whether that is a good practice. It will push some of the blood into the baby. There are some concerns about the rapid bolus of fluid and whether that may cause an increase in brain bleeding. We just don't know at this point. And as we speak, studies are happening. ILCOR has decided as soon as the studies are completed, they will change the recommendations and not wait 5 years. So they have already planned to let us know before 5 more years pass whether we should do that. So at this point, they recommend against the routine use of cord milking, but it may be considered a viable option in an emergency. So for the next step, for a premature infant, provide warmth, maintain the temperature, position the airway, clear secretions if needed, so no more routine suctioning, and dry and stimulate. For thermoregulation, it's recommended for a non-asphyxiated newborn temperature to be maintained between 36.5 and 37.5, both after birth and throughout the resuscitation or stabilization. So important to assign a nurse or someone to continuously monitor the temperature every few minutes. All newborns are at risk for hypothermia after birth because of the relatively cool environment. I noticed here in Panama, lots of air conditioning. The obstetricians like the operating room very cold so they don't get hot. We know that the babies have a high surface area to the volume. And we know for babies that are cold, especially premature babies, they have a much higher risk then for morbidity and mortality. And the babies that are the smallest are at increased risk. We know that cold stress in a premature baby leads to more apnea, more hypoglycemia, the surfactant does not work as well, they have more acidosis, more intraventricular hemorrhage, a higher incidence of late onset sepsis, and more mortality. So this was a study looking at morbidities of babies less than 1,500 grams from the NICHD network. For every 1 degree decrease in admission temperature that the baby was below the 36 desired temperature, the odds of late onset sepsis increased by 11%, and for every 1 degree centigrade decrease, the odds of death increased by 28%. So just keeping that baby in a normal temperature decreases the death. What are some of the strategies we can use to provide the warmth? For all of the babies, keeping the room where the baby is being resuscitated a little bit warmer, warm blankets for drying, and hats. For newborns requiring resuscitation, using the radiant warmer, warmed, humidified gases, and for a premature infant, using the polyethylene occlusive wrapping for those less than 1,000 grams, the heated mattresses or the sodium acetate mattresses that you activate when the baby is born, and then hats, especially wool or plastic, are found to be very effective. So you can see a baby here. So the occlusive wrap for tiny babies less than 1,000 grams, here's a baby placed in the bag immediately. So undried, they're placed immediately in the plastic wrap covering the body, and they're placed on the chemical mattress, and then the hat is placed. So again, we see that the admission temperature to the NICU favors the wrap right here. So these outcomes were improved by putting the baby in the wrap. So how can you monitor the temperature in the delivery room? The recommended ways are an axillary temperature or the servo control on the radiant warmer. So if you have the baby in the radiant warmer, making sure they're on the servo control. Using humidified and warmed air, this was a study that showed using warm air improves the admission temperature. So these are the babies at gestational ages. And for every gestational age, the darker bars are the cold air, the open bars in white are the warm air, and the temperature was always better for the babies that were randomized to the warm air. So make sure that you use that when resuscitating a small baby. Again, very obvious, you know this position to open the airway, slightly extending the neck to the sniffing position. And suctioning is now recommended only if it is really needed. So if there are copious secretions or if the airway is really blocked, recommending suctioning with a bulb syringe, again, mouth before nose, and you already know this. How do we stimulate a baby? No more than 30 seconds, maybe even less, but tapping the foot, rubbing the back, rubbing the stomach. Again, we see various ways throughout the world that squeezing the rib cage, forcing the thighs, putting something up the anus, using hot or cold compresses, don't do that. So the next step within the 60 seconds, again, after the initial steps, further actions are based on the simultaneous assessment of heart rate and respiratory effort. So we're right here. We then say, is the baby apneic, gasping, and what is the heart rate? If the baby is having problems, we go down this pathway. If the baby is not having problems breathing, we look over to this pathway. And then we see if the baby is having labored breathing or is still cyanotic, and do this. So what are, again, some of the changes? Heart rate assessment remains the most important indicator of an effective and successful resuscitation in the premature infant. So as you can see from the algorithm, there are many places that you need to be able to assess the heart rate accurately. Here, 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 and when you give medication, continuously assessing the heart rate. So how do we recommend assessing the heart rate? For the initial assessment, using a stethoscope is now preferred. We used to recommend palpating the umbilical cord, but we now know that really is not very reliable and it's not very accurate. So we should not be teaching people to do that as much as we have been. This was a study looking at determining the heart rates in babies at birth. All of the babies had a heart rate above 100 in this study. They compared looking at the cord palpation, the brachial pulse, or the femoral pulse. So the femoral pulse in black, the brachial pulse in white, and the cord pulse here. And even though the babies all had a heart rate above 100, many of them were not detectable by the pulse or the cord pulse. Many of them thought the heart rate was lower, and only about half could really detect that there was an accurate heart rate. So that is why we don't recommend it. Cord palpation is more accurate than pulses, but it's still only accurate about half of the time. So after the initial steps, further actions are again based on the simultaneous assessment of the heart rate and the respiratory effort. So let me focus on the less sick babies over here. We check if there's labored breathing, if there's cyanosis. If there is, we want to position and clear the airway, put on an oxygen saturation monitor, give extra oxygen as needed. So at this point, you've not yet given oxygen, and consider CPAP. So this should all have been very rapid. Pulse oximetry, again, should be placed on the right hand because that is the most oxygenated blood. And it should be used to determine whether you are oxygenating because assessment of color by your eyes is not very accurate. This was a study that asked experienced doctors in resuscitations, they showed them videos of different babies and said, tell me when you think this baby is pink. So everyone looked at 20 videos and they had to answer when the baby was pink. So some of the babies who were obviously sick, they said the baby was pink, but the saturation was only in the 40s. So they were delusional. Some said the baby isn't pink until it was almost 100 on these different videos. So you can see we are not very accurate using our eyes. So how much oxygen should we use? We know that it can be too much of a good thing, and more is not always better. We know that giving oxygen causes pulmonary vasoconstriction, causes oxygen radicals, and leads to all of these oxygen-free radicals and increasing the contractility, so worsening the lungs. The recent study where babies that were not ill were immediately monitored for oxygen saturation right after birth, so starting at 1 minute, and we saw that at 1 minute, babies that became normal and did not need intervention only had a saturation of 60%. But we've been trying to get that 1 minute APGAR of 10, where the baby would be pink. So we've been doing the wrong thing all those years. The baby, obviously in utero, only had a saturation in the 30s or 40s. So it makes sense that over time, we should go more slowly. And for the term babies, it was even higher, faster. So the new recommendations, again, this is similar from the last recommendation, is at 1 minute, the saturation should only be 60 to 65, and if you are giving oxygen and above this number, you should turn it down. It's easy to remember, start with 60 in every minute, add 5% until you end up at 10 minutes with 85 to 95%. In babies that were using oxygen, we want to know how much should we start with. The title has been cut off here, but it was a study looking at starting at room air or 100% oxygen, and we see that the babies on the 100% oxygen, trying to keep the sats, had to come down. The babies starting on room air had to come up. But you can see the babies on 100% had many minutes where the oxygen was too high and probably damaging. For some of the premature babies, it may be that room air was too low and they may have needed to start earlier. So this was a study that looked at babies between 30 and 90% oxygen. They found that 30% oxygen was better. The babies that were in the lower oxygen, they found they had lower oxidative markers at day 1 and day 3 with the lower oxygen, and lower inflammatory markers at days 1 and 21 with lower oxygen. So our recommendations are to not use as much oxygen. And we also know that the babies that had 21% that were on the lower oxygen, the 30% that they started, more of them were breathing room air when they got to the NICU. So even though they started at lower oxygen, they needed less oxygen ultimately. And we also know the lower oxygen group was on oxygen lesser time compared to the higher oxygen. They were on the mechanical ventilator a shorter time, and they were on CPAP a shorter time. So not being too aggressive with oxygen initially really improved their outcomes, and they had less BPD down the road. So again, you must have the ability to blend oxygen. If you can only do room air or 100%, it's probably better to start at room air and then go all the way to 100% if you need to. So again, the recommendation, begin with 21% oxygen when applying PPV for a baby above 35 weeks, 21 to 30% oxygen when less than 30 weeks. Free flow, you could start at 30% and consider a trial of CPAP if you're then unable to achieve your target oxygen saturation with 100% free flow oxygen. So again, using less oxygen had favorable outcomes on this side mortality before discharge, all of the studies have shown a lower mortality with less oxygen, going along with those recommendations of 60 to 65 at 1 minute, 65 to 70 at 2 minutes. So again, following this. And it's good to have this at your resuscitation bed so that you know what to titrate at any given moment. So after the initial steps, if the heart rate and respiratory effort are adequate, but there is increased work of breathing or cyanosis, CPAP can be considered. And again, here is a baby in the bag with CPAP being applied. And there have been 3 large randomized controlled trials of CPAP of over 2,000 babies. We know that those babies did not do any better or do any worse, so it was just as effective as intubating immediately. So for continuously or spontaneously breathing babies with RDS requiring support, the initial use of CPAP is recommended rather than intubation and positive pressure ventilation and giving surfactant right away. So again, this is for a spontaneously breathing premature baby. CPAP alone is recommended rather than intubating, regardless of how premature the baby is. So again, we know that the CPAP might help establish functional residual capacity. It can be administered with a flow inflating bag or a T-piece connector, but you cannot give CPAP with a self-inflating bag. So those are not recommended if you are resuscitating a premature baby. So the next steps, let's say your baby is sicker, you're not able to use CPAP alone, what do you need to do? So the baby is apneic or gasping, or the heart rate is below 100. Now apply positive pressure ventilation and consider putting the baby on an EKG monitor as well as an oxygen saturation monitor. So you can give positive pressure with a self-inflating bag or a flow-inflating bag or a T-piece connector. And again, what type do you use? The T-piece is more consistent ventilation from breath to breath. You need a flow source, and you can reach 100% oxygen. We recommend starting at 20 to 25 over a PEEP of 5. And again, the advantage is the breaths are always more consistent. There's a flow inflating bag. Again, you need to have a gas source, but you can go to 100%. And the self-inflating bag must be used with a pressure manometer. You cannot maintain PEEP with it, but the good point is you don't need a flow source, and you cannot get to 100% oxygen. So in preterm infants, it is recommended to use something that can provide PEEP, and there has been a study of almost 600 babies using PEEP, and we showed that decreased the maximum oxygen concentration needed, and it ensured that the baby's lungs remained inflated rather than collapsing each time with every breath. So the assessment of the heart rate. If you cannot auscultate or hear the heart rate with your stethoscope and the baby is not vigorous, the recommendation is to quickly apply a pulse oximeter sensor or an EKG lead and utilize that to assess the heart rate. If you are using positive pressure, consider putting the baby on an actual cardiac monitor, and during chest compressions, that is strongly recommended. The EKG is faster and much more accurate than pulse oximetry to measure the heart rate. And if you don't have a heart rate monitor at every bedside, consider getting one portable one for your unit. So there was a study that looked at how much time is required to determine the heart rate from an EKG compared to a pulse ox. If the sound is turned up and you're concentrating on the baby, can you hear the heart rate? So for the time to place the baby on an EKG versus the pulse ox and get a reading, in very low birth weight infants, it was 12 seconds faster on the EKG. For the bigger babies, 6 seconds faster, which was no different. But for the very small babies, the EKG was much faster. And then the time to get an audible heart rate signal from the EKG once it was on, 2 seconds for the EKG, compared to 24 seconds for the pulse ox. So again, the recommendation is consider applying the EKG much more rapid than we have in the past. So again, for the first minutes of resuscitation, 93% of the babies had an EKG rate that could be determined, with only half from the pulse ox in this study. So to review the changes for that first assessment, heart rate after 15 seconds of positive pressure ventilation. If the heart rate is increasing, you announce heart rate is increasing. Continue your positive pressure. Do a second heart rate assessment after another 15 seconds of PPV. If you are listening and the heart rate is not increasing and the chest is moving, announce heart rate is not increasing, but the chest is moving. Continue the positive pressure ventilation. Get another heart rate assessment after 15 seconds of positive pressure. If the heart rate is not increasing and your chest is not moving, you announce heart rate is not increasing, chest is not moving. So you want to reposition the baby, consider positive pressure ventilation, and continue your intervention for 60 seconds before you measure the heart rate again. Again, Mr. Sopa, adjust the mask, reposition the airway, suction the mouth if there are secretions, open the mouth, increase the pressure, and consider another airway like intubation. The second assessment, so the heart rate after 30 seconds of positive pressure ventilation that moves the chest. If the heart rate is at least 100 beats per minute, continue to the positive pressure ventilation at 40 to 60 until there is spontaneous effort. If the heart rate is still low, reassess, are you ventilating correctly, and take corrective steps. If the heart rate is low, reassess your ventilation, increase your ventilation, consider an alternate airway, and if there is no improvement, continue and add chest compressions. So the next steps are, the heart rate is below 100, you've looked at the chest, you've taken corrective steps, you intubated, and now you listen, is the heart rate below 60? If the heart rate is below 60, you intubate and now start chest compressions and coordinate it with the positive pressure ventilation. Increase up to 100%, making sure the baby is on an EKG monitor. So again, intubate if there's no response. And how do you know that you're correctly intubated? Just to remind you, the ET CO2 detector color change should go from purple to yellow. Is there equal chest rise? Did you visualize the cords when intubating? Is there mist in the ET tube? Check the tip to lip placement. Can you hear equal breath sounds? Or maybe look again with the laryngoscope. Again, the CO2 detector turning from purple to yellow. And if there is not good perfusion, it will take a little while for that color to change until the body can detect that the carbon dioxide has been removed. Again, consider an LMA as an alternate method. In the US, our residents intubate less and less, so nobody knows how to do it anymore. And then they ask the oldest attending who hasn't intubated in 5 years to do it. So make sure that you know how to potentially put in an LMA. Again, the method is just very easy in the posterior pharynx, sliding it down and inflating the cuff. It's very effective. We had a recent term baby with severe heart disease that had a significant cleft palate but was breathing. So we wanted CPAP, but we couldn't put CPAP because there was no nose. So we used an LMA, and it was very effective and avoided intubating the baby. So again, you're assessing the heart rate. Is it below 60? Start chest compressions and coordinate. Just a reminder, compress to the depth of 1/3 the AP diameter of the chest, the lower third of the sternum. New recommendation is only using the 2-thumb technique, not the 2-finger technique anymore. 3-to-1 compression to ventilation ratio, 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. So again, here is someone using the mask and doing the chest compressions. They may want to go ahead and intubate. Again, for the 2 thumb, it is better compressions, more effective, less fatiguing, and better blood pressure. So no more 2 finger. Coordinate is important to avoid breathing and doing chest compressions at the same time. And most importantly now is we recommend avoiding frequent interruptions to check the heart rate. So instead of every 30 seconds checking the heart rate, the new recommendation is check it every 60 seconds once you start chest compressions. And why? Here's a study looking at the blood pressure. If there were continuous compressions, the blood pressure stayed higher. But if you did 30 seconds, by the time then you tried to listen, do some breathing, the heart rate, blood pressure drops. You have to go back to the ventilation to get the blood pressure up, then it drops again. And we realized there were long periods of time that the heart was not being perfused because we were stopping so often to check for the heart rate once we started compressions. If the ET tube is in place and you think you may need medication, you can move to the head of the bed. So here is the ET tube, person doing the chest compressions, but moving around to the side so she has an easier time doing the chest compressions. And it also leaves this area free for someone to put in an umbilical line. If the heart rate is still less than 60, consider IV epinephrine and consider that you may need to give volume, although in a premature baby, you almost never need to give volume in the delivery room. So again, this is no change for the IV epinephrine, 1 to 10,000, 0.1 to 0.3 ml per kilogram, so you have to estimate. If you need to give it endotracheal, the dose is much higher. It's 0.5 to 1 ml. So you can use 2 different syringes to differentiate the dose. And remember to debrief. So to talk about the resuscitation with your team, to say, what did we do well? Was everything ready? What could we do better? Was there equipment missing? How did things go? And I'm just going to finish then talking about the golden hour. So this is a relatively new concept about that first hour of life being so critical for a premature baby, and what we do in that first hour makes such a difference in the life of that baby and how sick they become. So there are 10 steps that I wrote down, and I'll go through these in a little more detail. Optimize communication and teamwork, establish family communication and partnership, maintain the temperature, monitor the oxygen saturation and heart rate, titrate the oxygen according to the current guidelines, avoid extremes in the PaCO2 values using the best practices for positive pressure ventilation, establish timely vascular access either during or following delivery, administer IV fluids with amino acids within 1 hour, monitor and prevent hypoglycemia. If antibiotics are needed, give those within 1 hour, and intubate, give surfactant only if indicated and needed. So again, optimize communication and teamwork checklist, and have someone staying by the bedside to make sure everything gets done in an hour. In our unit, when we assigned the fellow to stay at the bed, everything happened. But before that, they would wander here and wander there and come back. Nothing got done. So now one person has to stay. We make sure we talk to the family. They're very worried. And we should send one person at least to talk with them. Maintaining the temperature we already talked about in the delivery room, but making sure when the baby gets to your NICU that the temperature is not too cold as well, because the babies can get very cold moving from that resuscitation room to the NICU. Monitoring the oxygen saturation, so we already talked about the first few minutes But now we recommend maintaining the oxygen saturation for a premature 90 to 95, although there's some controversy, perhaps 85 to 95. We don't know 100%, but it seems more places are recommending the 90 to 95% for all premature babies that are receiving extra oxygen. And titrate always using the lowest oxygen needed. Avoiding the extremes. We know that CPAP, if a baby is breathing, is just as effective as intubation for chronic lung disease and death, and probably causes much less lung damage. And positive pressure ventilation with a CPAP, you can use a face mask, nasal IMV, nasal synchronized IMV, conventional ventilation, and high frequency. So a lot of different methods to ventilate. The vascular access, the umbilical lines, or PIV, should be placed within 30 to 60 minutes, and giving the IV fluids with amino acids. I know Dr. New is going to talk about the importance of giving protein right away. When I think about how I was taught when I was a fellow in training 30 years ago, it makes me cry because we did terrible things for nutrition for those babies, and now we do much better with giving good glucose, giving amino acids, and starting good nutrition, even on day one within that first hour. And give antibiotics, and only intubate and give surfactant if you really need it. And you can always intubate, give the surfactant, and if the baby is breathing, extubate to CPAP. And we also have in Mississippi a post-resuscitation debriefing checklist. So we have the nurse and the fellow fill out this form. What kind of delivery it was there cord clamping, information about the delivery, was everything done on time, and then when we get to the NICU, what was the first blood gas, what was the oxygen, how many minutes it took us to start the IV, how many minutes it took us to give antibiotics, and we collect this information and we review it every month to see what we can do better. And then did we debrief? Did we talk about things? So we do this on every single baby that is less than 1,500 grams. And we think it has improved our outcomes. Muchas gracias.